Welcome again to ECCMID TV from the ECCMID meeting here in Madrid in 2018. There's so many interesting people and scientists here. Another interviewee in a row is Duncan Cranendonk. Cranendonk's obviously a Dutch name, isn't it?
It's very Dutch, yes, and it's horrible in English, but it's, yeah.
Is it Cranendonk? How do you pronounce it?
Cranendonk.
Cranendonk, so we say it a little bit like Cranendonk. I'll try that. You're from the Academic Medical Center from the University of Amsterdam.
Correct.
And you have been here at the ECCMID Congress since?
Since the beginning, so since Saturday morning.
The whole period. How you like it so far?
It's good, it's a nice atmosphere, it's very widely set up, lots of interesting people, interesting talks.
You presented some new data on the comparison between a short-term and a longer-term treatment of cellulitis. Tell me more about it.
Well, we had a study which was intended to run in patients hospitalized with cellulitis to shorten therapy duration, because we know that antibiotic consumption in general drives the development of antimicrobial resistance. So if you can shorten or reduce consumption, we can hopefully reduce the resistance rates. So over the last few years, many studies have shown that many infections can be treated for a short duration of therapy, which proves to be equally safe than the standard, long time ago thought of durations. We thought, why not check if the same holds true for cellulitis? It's one of the most recent or most common infectious reasons for hospital admission, and one of the most common infections in general. So if we can reduce the duration of therapy in cellulitis, we'll reduce a lot of antimicrobial use. So we investigated if we could shorten therapy duration from the standard 12 days to 6 days of therapy.
So half it?
To half, yeah. It's a general idea to always check half. So we investigated in 11 hospitals to see if we could recruit patients, and we randomized them after 5 or 6 days to, if they improved, to either 6 more days of antibiotics, so a total of 12 days, or to 6 more days placebo, so a total of 6 days antibiotics. And we compared the two groups on day 14 and day 28. By day 14, they had to be cured, so the symptoms had to be cured, and by day 28, they should be relapse-free. And we defined relapse as being as not receiving new antibiotics for the same infection. And in the end, we showed that in both groups there are equal rates of cure without relapse. However, our secondary endpoint looks at the relapse rates up to day 90, and we see that the short therapy duration group, so the 6-day therapy duration, gives more and more frequent infections than the long therapy group. So on that data, we would not recommend to shorten therapy duration because you have far more relapses in the months after.
So that's interesting. I just want to quote something that Spellberg in the Journal of American Medical Journal said. Other than tuberculosis, which is caused by a very slow replicative organism that spends much of its time in a non-replicating state, for every bacterial infection for which trials have compared short course with longer course antibiotic therapy, short course therapy has been just as effective. So this result, in the first place, must be a surprise.
Yeah. Initially we started the study with the same concept. We thought, well, we're probably going to show that the short therapy duration is equally as effective. Yeah, so it was a big surprise to us.
And you wouldn't have found out if you stopped the trial at, let's say, day 60 or even at day 80.
Yeah, well, maybe 60 or 80 maybe, but at day 30, no, we wouldn't have found this difference. No, yeah.
So it was a kind of surprise.
It was a kind of surprise, but it was, well, not a pleasant surprise, but it was an interesting surprise.
It was an interesting surprise, and it has an impact on the clinical work, hasn't it?
Well, yes and no. I mean, yes, it does, or no, it has no impact because now we won't change the therapy duration.
Right.
The current dogma still stands. However, it will change because now we maybe have to look more at the late-term outcomes of other infections as well. You might think that maybe, I don't know, urinary tract infections also, if you cure for shorter durations, might lead to more relapses.
Yeah, I just thought about this, that this might hold true for other bacterial infections as well, and we just don't know yet.
Yeah, although one of my old professors in infectious diseases, who is now long retired, he used to say that the same thing kind of, probably all infections will be shorter except for skin infections. And well, most people said, well, we'll wait and see, but now it turns out in the end he was right. So, yeah.
Very good research, Duncan, and it was very nice to have you here. Thank you for sharing your thoughts here, and enjoy your time in ECCMID.
Thank you, you as well.
Thank you very much.